Good day, my dear postgraduate students. This was a history that was given to us in the last class. A 43-year-old male presented with sudden and progressively increasing intermittent seizures. See that the patient is 43 years old. And here I am finding a tumor which has got a peculiar pattern. It has got lobulations. But more than that, the cells are arranged in sheets and they have got a rather uniform pattern which is classically described in the subsequent slides. Welcome to Glide the Slide, number 12. So what I would like you people to appreciate is there is a polygonal or a hexagonal outline of the cells that could be seen. Secondly, there is a clear cytoplasm, and this is always described as something called as a boxed-in appearance or a fried egg appearance. And the diagnosis is oligodendroglioma. Large cells, clear cells arranged in sheets, this kind of a pattern. If it occurs in the testis, the diagnosis would be seminoma. If it is in the ovary, a dysgerminoma. And a third region where you can get a similar tumor will be the pinealome. But now I am not seeing lymphocytes and the patient has got history of seizures. Obviously a cranial tumor, it is an oligodendroglioma. Now, I would like you people to kindly describe this particular one. Look at this. There is something that I can appreciate. One is the vascularity. There is a vascularity, but then the tumor cells are being arranged in sheets. Let us have a better look at it. Again, the same fried egg or the boxed-in appearance, tumor cells being arranged in sheets, not much of pleomorphism, mitotic figures, or necrosis. And I find that if you were to imagine, there is some kind of a lobulation that is seen, and the septae are quite vascular, described as a chicken wire pattern. That is classical of this. Not much of inflammation or fibrosis is seen in this. Homogeneous, polygonal, clear cytoplasm, central nucleus. What more do you know? And grossly, this would be the appearance, thanks to Wikidoc, the site for Victor notes. I find that there is a large tumor which is quite fleshy, myxoid, solid, but there can be areas of cystic degeneration also, better circumscribed than the astrocytoma. So look at this oligodendroglioma, very well brought out by this MRI. The cytoplasm will be showing a fried egg appearance. And here, in other modes, it is quite difficult to pick up because it is ill-defined and it goes into the surrounding tissue. Whereas here, it is very well demarcated, brought out along with the cystic degeneration. There is also an enlargement of the lesion. Therefore, there is a push of the central sulcus to the opposite side. Described by Bailey and Busey in 1829 or 1929. So, it resembles the oligodendrocytes, 5 to 6% of the gliomas. Insidious in onset, slow growing. But because of it, there will be the pressure effects, that can be headache and convulsions. Cerebral hemisphere is the most common site, and it is more circumscribed than the astrocytoma. This will be the grading of the various brain tumors. I will not be going into the theory of it. You can just go through it. What comes under grade 1, grade 2, diffuse, and then grade 4. So oligodendroglioma is basically a low-grade tumor over here. If it is anaplastic, it will be going in for grade 3. So it starts in the white matter, extends to the cortex. Soft, grayish pink, gelatinous. It will be having a myxoid matrix. That can be cystic changes. The tumor cells will be showing cytoplasmic dissolution. So the clear cytoplasm that we see is supposed to be an artifact. So high-grade tumors will be more polymorphous. Calcospheroids or concentric rings can be seen, which is classical of it. And chicken wire due to thin-walled blood vessels. So these are all the features of the oligodendroglioma. I think you can answer a question on it as well. The fried egg appearance, Ackerman insists that it is an artifact because when you do a frozen section, it is not seen. Also, in intraoperative, when they try to prepare a smear or anything, squash, etc., this is not seen. Moreover, in frozen section, there can be eccentric nucleus, eosinophilic cytoplasm, somewhat described as mini gemstocytes. Oligodendroglioma along with astrocytoma comes under the grade. So there are some world intracytoplasmic inclusions that I had mentioned earlier. Some books say that there can be a salt and pepper pattern of chromatin in the nucleus. The markers and the progress. It is intensely positive for GFAP. So the single marker that is dependable upon is GFAP. There are other markers, S100, LEU7, MAP2, etc., but they are all non-specific. So it is a progressive neuronal infiltration is seen. Distant metastasis is quite rare. We shall glide to the next slide. And this is the history that is given. We shall be seeing it in detail in the next class. So I'll be showing you a higher magnification of the same thing. I would like you to kindly appreciate it. Again, go back. Thank you for your patience.